section and the American Physical Therapy Association, as well as the geriatric section, they're going to look at all the evidence, right? And based off the evidence, they're going to pull the recommendations. Here is, they're the ones who are synthesizing. So we do not have to synthesize the evidence, because we can look at the evidence, every single one, but what the clinical practice guideline does is it provides us the opportunity to look at the decisions, at those evidence where the experts have already looked at it, and then they summarize it for us and they give their recommendation. So you can see that there will be different types of recommendation in a clinical practice guideline. So let's just define the clinical practice guidelines. So CPGs, right, based on the National Institutes of Health, it is a systematically developed statements, right? So clinical practice guideline, when we look at them, it's not like validity studies. It's not like the different types of interventional studies. When you look at it, it's all mostly statements, right? They have statements, but then they provide you the evidence. But the statement tells us what to do, right, with a certain condition that we meet in the clinic. The goal of it is to assist practitioners, healthcare practitioners, and the patients, right, to make the appropriate decisions regarding their healthcare and the condition that they have. So when we look at the CPG, right, it contains the guideline statements. So when we're looking at the CPG, I'm going to pull an example later. Those guideline statements are the statements based off the research and the recommendation of the experts, the panel of experts that have looked at those high quality evidence. They look at the published literature and they have underwent a rigorous systematic review. So all these articles, right, meta-analysis as the highest level of evidence, right? We know that the case series are the lower forms of evidence. There's just one case study, or then multiple case studies will be a case series. And then you have the randomized control trials where there's two groups that are compared, right? The intervention and then the control group, the one that doesn't receive the treatment. And then based on, right, summarizing those studies, we come up with a systematic review or meta-analysis. Well, clinical practice guideline pushes this even further by recruiting the panel of experts, right? The top experts in the field of physical therapy, not just that specialty area, but the subspecialty within that specialty area, in order to create those statements that physical therapists can use as a recipe book to make those clinical decisions regarding the diagnosis. So think of the middle one, right? The middle portion of the pyramid, the RCTs, or the randomized controlled trials, the cohorts.
Love the work that you do with them, love you for the tools and resources you give them so they can hopefully age gracefully. So I have some objectives today in the talk, and what I'm going to do is go through this presentation. I'm happy to answer some questions afterwards. So tools and resources to assist people as they age gracefully. So physical therapy is an awesome tool, but it doesn't usually go on forever. So if you can give them something to take with them, some knowledge, as Morris was talking about, you bring the knowledge to them, and you also give them action items to fulfill their goals. Burden of musculoskeletal disorders in the USA, and it's about 10,000 people a day reach 65. So there's a lot of people out there that are potentially patients or potentially suffering with some pain. So life expectancy is around 76.3 years. It's declining since 2016. COVID didn't help too much, but it's still declining. Musculoskeletal disorders affecting about 75% of the people over 65. That's 3 out of 4. And even if you're younger, even in your teens and early 30s, it's still around 40% and even up to 50. So it affects about 127 million Americans, probably a little bit more now, but it's about that. And the annual care is around $874 billion a year to care for people with musculoskeletal disorders. Normal bone mass, so it's one less degree of severity compared to osteoporosis, in which there's a lower than normal bone mass, and the bone mineral density of the thickness, or the amount of mineral contained in a certain amount of bone. So what happens when people are osteoporotic and osteopenic? Well, they have a simple trip and fall, or they land on their buttocks or something like that. They can sustain a fracture or a deep bruise to the bone and cause a higher likelihood of injury. So what's a compression fracture? Well, fracture in the medical term is a break, which is the lay term. Broken bone, fractured bone, same thing. Compression, as the term describes, you're compressing two things against each other. Usually it's a joint, which is the coming together of two or more bones to create motion. So when you have a compression fracture, They break the bone in a direct axial impact or chronic axial compression across a weight-bearing joint. So that could be your ankle, your knee, your hip, or anywhere around your back. Inflammation that you have in and around muscles, bones, and joints. Topical products becoming more favorable these days because they don't really enter your system too much, but those can be like an Aspercreme or a Voltaren gel. It's an anti-inflammatory. There's also some nerve-altering perception things like capsaicin cream or biofreeze. And there's a lot of topical products, and CBD is also getting more common where it's like it's into your system and calms some of the feeling of pain. I for ice. Ice is also, to me, very important as long as it's used. Plus technology, I like to call it corrective exercise therapy software. These days I'm focusing on the fascia system, which is really more than one joint and more than one plane. So it's a full kinetic chain exercise therapy software that if someone has a sprained ankle, we can also work a little bit on their hip and their knee musculature to help them kind of stabilize their ankle. Well, the ulnar nerve travels, from your neck down into your armpit, down to the medial aspect of your elbow, down into your medial aspect of your wrist. So sometimes it's operated on here, but a transposition is mainly at the elbow. I don't know if you can see my elbow, but
we're going to talk about the art and science of gamification and play in therapies. So we often think about play in the sense of something that's non-goal oriented, something that doesn't provide any specific benefit, that's something that maybe is childish. And what I really want to talk about today is some of the fundamental some scientific evidence that shows what play is at a deeper level, both in terms of the functioning of the body and the psychology, and how that relates to clinical outcomes. So we're going to go into all of that. Bridging clinic and home. So how do we use these types of technologies both in a therapy setting, whether it be outpatient, skilled nursing, inpatient rehab, home health, and bringing them to patients and having patients use this in their homes, and also having that bridge, so being able to track and monitor patients' progress. And then finally, I'm going to give you guys a live technology demo. So you're going to see our latest program in action. I'm going to talk about how it all works, and I'm going to go step by step so you can see what this is all about, and hopefully this will stimulate some ideas and questions, and I'm looking forward to answering and engaging with you.
I'm going to be stressing today. You can apply some of these concepts to your other clients. So really today, I'm hoping that your observation skills, maybe you learn something different on when you're looking at a client, and then I'm really into integrating whatever you're doing in the sensory systems. So we'll be talking about that. But one thing I thought as we started, and it's up to everyone, right now I only see a few screens, but we've been sitting for a while, it's a Friday night, right? So does anybody, or can you let me know, I can try to put the chat here, would everybody like to exercise and get up a little bit to move? So that's one thing I was thinking to get us all going. So anybody's welcome to take their camera. I think the first thing before you're even with a client, especially somebody with Parkinson's, is tell them that they're gonna do well on this. You're going to this is something that, and if they don't, hey, you're going to get better at this. We just have to practice. Really, really important. So I think the minute you're with your client and starting to talk, think about that before you're even doing any of your balance training. But some could be side effects of their medications or some surgeries such as DBS. So we're not going to go into full of this, and let me know I can, but I'm going to kind of move to kind of give you a glimpse of all of it. But of course, if we were here longer, we can go into each part, but visual acuity can be affected, your color vision. We're going to talk a little bit about eye movement problems, because that's something that we can assess a little bit, looking at smooth pursuits, saccades, and convergence. Your visual processing, right? It can be more central oriented, your peripheral vision, object perception, visual spatial construction, and motion perception. And lastly, looking at spatial neglect. So similar to somebody who might have had a stroke, patients with left-sided Parkinson's disease actually do perceive objects within their left visual field smaller than the right. So if you have somebody who keeps bumping into something, look at your clients when they're doing that. That is a head writing response. That's our vestibular system working. So I love kayaking. If you pretend to be kayaking, now you're using a hip strategy while you're having them, I put a beanbag on their head and work on keeping their head reference. That would be and look straight ahead, back and forth. So I do a lot of targets when they're walking or balance. and I use like a wall mat for even some of the things I use for my system, is that even if they're looking down at a foot pad, then they have to look straight ahead. So teaching their eyes to go up and down will help you. If they lose their balance with eye movements, right, they might lose every time I look up, I fall backwards. So that's something that you can kind of start training if it's vertical gaze. Can you train vertical gaze without their head moving? Or if they can't move their head, right, if their eyes are going up and down, is it something that they can't, so let's say their eyes, they can't do this, they have PSP and their eyes don't move, then I will really up-train head motions, making sure that they can move their head up and down and not lose their balance, because they're going to have to do that even more, because now they really have to do that to be able to look all around them. So does that answer your question, Marie? I'm not sure if you can give me a thumbs up, let me know. All right. Am I moving too fast?
Now, these are examples of manual physical therapy. You know, there's a lot of techniques you can facilitate. You could use tools. You could use your hands. You could tape. You could massage. You could mobilize. And this guy over here in the bottom, who's really sad because he has needles in his face, would be myself. And when I took my dry needling course. Okay. Now, all right. So, what is manual physical therapy? We have options, as the pictures mentioned earlier. You know, talking about manual physical therapy online is very challenging. So today we are focused on the theories behind it, maybe some rationalization on what to do, how to do it, and why we're doing it. Okay, so different types of manual physical therapy would be, I'm a fan of this one. This is the simplest one. All right, so it would look like this. So for whatever reason you choose a joint that you want to mobilize, and you just use the grading that we would think that's appropriate for the patient's course. All right, so you choose a joint. In this case, it's a lumbar spine. I would say I'm on L4, and I would just do grade 1s. So grade 1s would be small amplitude oscillations. So grade 1 is before any tissue resistance. So it's very light. The only difference with grade 1s and 2s, they're both before tissue resistance, but grade 2 will be large amplitude. It's a little deeper, still before tissue resistance. Let me pause this real quick. Is I don't know, L4 transverse process, for example, right side. Now that's a straight UPA. Now when we do mobilization, what we need to look for is a comparable sign. It's great, and I love it when the patient tell me this is where my pain is. It's just one finger or two, maybe three. That'll be good. You know, I want us to realize that there's options to be thought about when we do mobilizations. Whether to do, for example, this is the first one is neutral and mid ranges. Now you can mobilize in a full extension, which is with a full press up, if the patient needs that, and if the patient is okay. Now in this position, my right hand on the middle picture, my right hand is doing a glide at the end of that side bending. All right, so this can be a common role is this on the right, if anybody knows. Flynn et al.'s clinical prediction rule for lumbar mobilization used that role, Chicago role, and that's the decision that we have to make. All right, so same things with this mobilizations. It's just different angles. You know, seeing this picture doesn't always have to be grade 5s. I could be doing. This is an old video, guys. Pardon the old video. So it's CT junction. So let's watch that again, okay, real quick. Okay. All right. So again, in this position, I can choose to do a passive range of motion with my left hand, or I could do a transverse glide with my right hand doing lower grades. I do not have to thrust here in this position.
Presentation is physical activity, exercise, and activated poles for older adults. So let's get going. People have seen hiking poles, and some of you may have seen Nordic walking poles, designed specifically as a fitness tool. Activated poles are different again. They're specifically designed to assist those who have some issues with walking, endurance, especially outdoors, or movement disorders such as Parkinson's disease. So they can be used as a tool for exercises targeting balance, strength, cognitive ability, and uneven gait, as well as a walking assistance. They were developed by Mandy Shintani, who's a Canadian OT, occupational therapist, and she had a master's in gerontology. She looked at Nordic walking poles and adapted them to suit the older clinical population that therapists such as myself, you step forward with your right foot, the left pole is put forward at the same level as your foot. So you don't put it in front or behind. And then you just take normal steps. So it's a normal step length. The bell-shaped tip is always flat, and your poles are always held vertically. You press down on the ledge of the handles for stability as you're planting the pole, and that gives you that extra bit of stability. Being able to walk outdoors in the sunshine safely, it's an excellent way to get your vitamin D. A bonus is that your morning sun helps to regulate your sleep better. So if you have a morning walk, even better. And finally, psychosocial benefits. Never discount psychosocial benefits. A lot of older adults live alone, and urban polling in a group or activated walking in a group can be done by older and younger walkers together. If you do a morning walk, you can have a cup of coffee afterwards or breakfast, and that's often the most rewarding part of the walk. Not only with your affected limb, but with your unaffected limb as well. And again, you get a nice upright posture, quite good for weight management. I want to just qualify that by saying exercising, as health professionals, we probably know that exercising once, twice a week is not going to do much for your weight management. But I have seen some good results with people who consistently exercise with poles every day in managing